Well, as I said, welcome to this REMAP CAP Paediatric specific webinar. And for those who don't know me, my name's Tony Gordon, and I'm the UK Chief Investigator for the platform. What we're going to do is give you, first of all, an introduction to the team. For those of you, obviously, most of you will be new to the trial, a little bit about its background, and we'll go through the domains that are open. Talk a little bit about the website where you can find lots of information about the trial, a little mention of around the electronic site file that we're hoping to pilot, some information about what to do with old amendments and so on, update about regular Q&A sessions, and a little bit about monitoring. So just to point out, REMAP CAP is an international global trial that's running in all continents around the world. And in the UK and Europe, our sponsor is actually UMC Utrecht. And there, the overall EU lead investigator is Lenny Durdy, and with Mark Bonton. And as I mentioned, I'm the overall UK lead. And here are the central trial team. Many of them are on the call today. And for others who may not be here now, you may get emails or you may see them come and visit your site over the conduct of the trial. And just to explain, particularly around influenza, it was actually about a year ago that we got funding from the NIHR. They put out a call for platform for influenza in hospitalized patients, and we were awarded that grant. And in that commission call, it specifically said they wanted to find, interventions, evaluate interventions for influenza for hospitalized patients, and that was at any part of the hospital, both in the general wards and the ICU, and also as well as adult patients. They did want to include pediatric patients. So we expanded our team, and hopefully you can see that the sort of national collaborative group we put together. Obviously, my background is in adult ICU, but we have now many ward-based doctors, respiratory, ID, virology experts. And of course, we've got pediatricians with us. So Liz Whitaker, who you'll hear from later, Ram from Paediatric ICU, and many of you will know Callum Semple as well. So overall, with the idea of REMAP CAP, it was set up pre-pandemic to be an international adaptive platform trial for severely ill patients with community-acquired pneumonia. And it was designed to be adaptive, that it could be running into pandemic and then adapt during a pandemic to generate evidence to reduce mortality, reduce ICU use, and reduce morbidity in these severely ill patients with community-acquired pneumonia. And to explain its overall structure, this figure sort of hopefully captures the idea of the platform. You've got the sort of blue line, which is the outer shell, to say this is a platform for community-acquired pneumonias. Very simple criteria to come into the overall platform. And then within the overall platform, we have what we call domains. And a domain is sort of a common therapeutic area. So as you'll see, there's an antiviral domain, a steroid domain, and an immune modulation domain. And almost you should think of each of the domains as almost like its own trial that runs in the overall platform, asking questions about the interventions within that domain. You can have specific outcome measures for that specific domain. But the idea is it shares the outcomes and shares much of the logistics of the overall platform to get your efficiencies. Patients may be eligible for one or more domains. They may be eligible for all three, for instance, and therefore you get answers more quickly. And also by being eligible and randomized to more than one domain, we can also potentially look at interventions, interactions between the different interventions, which may be important. We certainly saw that during COVID. And so To understand the overall design, we have different disease strata. We started studying community-acquired pneumonia pre-pandemic, and we were asking questions in bacterial pneumonia about what was the best antibiotic and what was the best duration. Obviously, with COVID, we had to adapt and included COVID interventions. And this slide sort of summarizes our results to date that we've produced from the overall international platform. I think our biggest result was seeing the interleukin-6 receptor antagonists, their beneficial effect of tocilizumab and saralimumab, and we were the first to report on those. The investigation of heparin was interesting, again, seeing the effect that if it was started on the ward in less sick patients, it led to benefit, but actually looked like it was maybe even harmful if started in the severely ill patients critically ill on the ICU. Our most recent publications just came out in the New England and JAMA 2 weeks ago. And again, evidence that suggested high dose vitamin C, which had been suggested for flu, looks like it was a clear signal that it actually may be harmful, but certainly not effective. And actually really strong signal suggestive that simvastatin may have a small beneficial effect in COVID-19. So a lot of evidence generated from the overall platform. And I think one of the things to explain when just talking about the results is a little bit about the methods we use. And REMAP-CAP uses a Bayesian hierarchical model. Now, I don't want to spend too long on the stats in too much detail, but I think it's important to explain it and why I think it's a neat design. So unlike a more traditional frequentist trial, we have no fixed sample size. So as you all know, in more traditional trials, you have to work out your power calculation based on an expected treatment effect and so on. Whereas in these Bayesian models, it works differently. We say, what do we know already? We generate more evidence. And when we get clear evidence of either the drug is beneficial or it's not working, then we stop enrolling. And we have predefined thresholds to define whether something is effective or ineffective, or maybe even harmful. Although we try to always stop if we just see that the drug is ineffective. And to explain sort of graphically how that might work in the Bayesian terms, we use this figure where we say an odds ratio of 1 means that the drug has no effect. It's the same as control. And the way we've set up our model here is an odds ratio greater than 1 suggests benefit. We start within the platform with what we call a weak neutral prior. And we say that this distribution, the probability is that there is no effect of the drug. So it's centered on that odds ratio of 1. And then we start randomizing patients and we run regular adaptive analysis and we start to generate evidence. This is looked at by an independent stats team so that investigators all remain blinded. We start to see some evidence, in this case, saying maybe there's some evidence that the drug is beneficial. You see the center of the distribution is above 1. But there's still a lot of uncertainty. We don't know that this drug is effective. We keep on randomizing, generating more evidence, run regular adaptive analysis until we get to, in this case, here you can see now a more than 99% probability that actually this drug is beneficial, having a beneficial effect. And that's when we would stop enrolling. If it's a big effect, we're likely to see it earlier and stop earlier. If it's a smaller effect, then you need a larger sample size. So now applying that to influenza, what we've done is added a influenza stratum, talking about the different causes of infection. And within that, we've split the disease around the pathogen into different subgroups, or as we would call them, strata. So we've been studying adults in COVID, and now we've included children. And we've divided the pediatric population into those over 12 and those 12 and under. The way the Bayesian hierarchical model works is it allows us to report separately for what are essentially different subgroups, or if actually the effect of a drug in a particular stratum or subgroup is very similar, you can borrow that information about the treatment effect between the different subgroups. something it's called dynamic borrowing within Bayesian analysis. So in other words, if the information is very similar across all age groups, we can sort of merge the data together and learn from the adult patients what the effect might also be on children. If, however, the effect is very different, we can report them separately. And I think this is a key thing in a pediatric trial where the population is always going to be smaller and likely to have less power. I think this is a useful way we will analyze the results. And just to say, the adults and the children over 12 are actually going to be grouped together. That's the plan. And then the separate group will be the under 12s. And we also recognize that treatment effects may vary not just by age of the patient, by the severity of their illness. And so actually we call these states, but essentially they're subgroups. And we have the critically ill patients who are in the severe state, which are patients in the ICU receiving respiratory or cardiovascular organ support. So the respiratory support is high flow nasal oxygen or above, or any inotrope of vasopressor infusion is cardiovascular organ support. All other patients are deemed not critically ill. They're in the moderate state. So that's all patients on the ward, or if they happen to be in an ICU and not receiving any of the organ supports. And again, we borrow the information between these different illness severities. So if it's similar, we can report them together, learn from all of the patients. But if they have very different effects, we can report them separately, just as we saw with the heparin, for instance. And so within the influenza stratum, what are we studying? We're looking within the antiviral domain, and we're looking at the antivirals of against flu, oseltamivir, baloxavir, and the combination of the two. Maybe these drugs that work in very different ways, maybe the combination is better, and we're comparing them against a control group. In the steroid domain, it's simple for pediatrics, we're just comparing dexamethasone versus control. In adults, we're looking at hydrocortisone as well, but in children, just dexamethasone versus control, similar to the COVID studies. And for the very sick patients who are critically ill in the ICU, and it's not open right now, but will be, we're also looking at immune modulation in the sicker patients, again, taking the evidence from severe COVID patients, tocilizumab and baricitinib, again, comparing against a control, which is just standard of care. So who are we studying? Well, as I said, first of all, we've got the overall platform criteria. Who's eligible for the platform? Well, it's very simple. Are you a patient who's in hospital, either on the ward or the ICU, with an acute illness due to respiratory tract infection? So, as I said, it's going to be adults or pediatric patients. And just in children, to make clear, it's 28 days or older. So then that's a corrected gestational age. So not neonates. Our exclusion criteria are, again, fairly simple. We just want to try and recruit patients fairly early in their illness rather than the chronic long-stay patients. So you have to be included within the first 14 days of hospital admission. If you're being randomized when you come into the ICU, we actually want to recruit them early in their critical illness. So within the first 48 hours of ICU admission, we think, again, the drugs are more likely to have their effect if we treat them early in their critical illness. And then the only other exclusions are at both sort of ends of the disease spectrum severity, that if the patient is actively dying, expected to die within the next 24 hours, and they're not being given full active care, and they may therefore be more on a palliative pathway, they would be excluded. And similarly, if the patient's about to go home and expected to go home within the next 24 hours, again, we can't make them better. They're already going to get better anyway, so they would be excluded. And you can only be included once in the platform in 90 days. So that's the only other exclusion to the platform. What I'm going to do now is show you some information about the domain, specifically the antiviral and the steroid domain. And what I'm going to do is, being an international trial, we have different leads for the different interventions. And so we've asked some of our international colleagues to present. So we've recorded these on video and I'll play them now for you. So. Right.
Hi, my name is Srinivas Murthy. I'm excited to talk to you about influenza antiviral strategies within REMAP CAP. I'm in Vancouver, Canada. I'm a critical care and infectious diseases doctor. I primarily practice in pediatrics. So I'm only going to take a few minutes. Randomized evidence for influenza antivirals in hospitalized patients. I would love for there to be any. Unfortunately, there are no fully enrolled prospective randomized trials of one of the most commonly used medications on the planet, oral oseltamivir, for hospitalized influenza patients. And so it is the year 2023. We've been using this medication for decades, and we do not have any randomized evidence for its benefit. And that's the gap that we're aiming to fill. So previously, and over the past couple of years, we've been enrolling patients with suspected or proven influenza to one of no antiviral, 5 days of oseltamivir, or 10 days of oseltamivir. We've got about 200 randomized in that domain thus far, with a primary outcome of 90-day mortality. Over the past year or so, we've amended this domain. This is what's currently active. The patients with proven influenza only, namely you need to have a positive test, and incorporating a new medication, baloxavir, that's approved in most countries around the world for the treatment of less complicated influenza. The patients will be randomized to one of no antiviral, 5 or 10 days of oseltamivir, and baloxavir, and then baloxavir in combination with 5 or 10 days of oseltamivir. These arms have been added, and patients are beginning to be recruited to these interventions around the world. The inclusion criteria are now patients with confirmed influenza infection, and that confirmation can be with any locally approved diagnostic test, and age greater than 28 days old. And so now we've included children in this domain. The exclusion criteria are more than 96 hours since hospital admission or more than 48 hours since ICU admission. The original intent of this domain was to focus on community-acquired infections. If you've already received 2 or more doses of oseltamivir or 1 dose of baloxavir, you're excluded. If there's a clinical decision by the clinical team that they really want to treat with an antiviral, then obviously they won't be eligible to participate. And for the baloxavir-containing interventions, pregnancy is a specific exclusion, given the lack of available data for safety. The baloxavir dosing regimen is as you see it. For adults, it's 40 milligrams on day 1 and 4, plus day 7 if the clinicians think that it's clinically indicated, i.e. the patient's not getting better. The oseltamivir dosing is for adults 75 milligrams twice daily for the duration of which they're randomized to. Children and renal dysfunction, we provide dosing recommendations, although there are local guidelines that inform that. We aim to be pragmatic and abide by those guidelines. For pediatrics, and one of the novel aspects of this domain is that we are including both kids and adults for a common disease that affects both children and adults. And we're incorporating novel statistical techniques to learn as much as possible about the benefit or harm in children using adult data that's generated during the trial. So hopefully we'll have some child-specific evidence that can inform child-specific practice from this large international platform. And as always, I do always want to emphasize the global and collaborative nature of REMAP CAP. We have sites on every continent and patients recruited from every continent, and we're excited to continue to engage with the larger community. Thanks.
Okay. We'll go over specific pediatric dosing later. What I'm going to do now is move to the next slide, which is around the steroids.
Hi, my name is Derek Angus. I am the chair of the corticosteroid domain for REMAP CAP, and I'd like to just briefly go over some changes to this domain. By way of background, REMAP CAP is addressing, broadly speaking, the question of whether corticosteroids help patients hospitalized with severe community-acquired pneumonia. This remains a question for which the answers are unclear. We have demonstrated benefit in severe COVID-19, but it's not exactly sure if there would be benefit in other types of CAP. There have been numerous randomized controlled trials and meta-analyses, but these results have been inconclusive. Some suggest benefit tending to be in sicker patients, but there are also adverse effects. And so some of the key unknowns that REMAP CAP was already designed to address include, should steroids be given for CAP due to influenza? How should dosing of steroids be given if the patient also has concomitant septic shock? And what to do if the patient has not just CAP, but also ARDS? There are three other questions that we would like to embrace in the design. One is, which corticosteroid should actually be used? There's evidence for benefit with both hydrocortisone and with dexamethasone. It's also unclear whether corticosteroids should be given to children with severe CAP, severe influenza. And it's also unclear what to do if the patient is sick and admitted to the hospital, but not so sick they're admitted to the ICU and meeting the severe state criteria. And so we've implemented three changes to the corticosteroid domain. First, we've added a new intervention, fixed course dexamethasone. Second, where sites have got approval for the updated core protocol, the domain can now be open for patients in moderate state, i.e. patients who are not receiving organ failure support in an ICU at the time of enrollment. And third, we've extended the age limit down to 28 days. In other words, children, other than neonates, are now eligible for enrollment in REMAP CAP. So the changes to the inclusion criteria are children from the age of 28 up through all of adult life. And if enrolling patients in the moderate state, there is one proviso, which is that they should not only be hospitalized, but they must be receiving some form of supplemental oxygen, by face mask, low or high flow non-invasive ventilation, for example. The exclusion criteria remain essentially unchanged: known hypersensitivity to any corticosteroid, intention to prescribe systemic corticosteroids for a reason other than CAP, for the severe state patients, if they've already been admitted to the ICU for more than 24 hours, and if the clinical team believes that participation in this domain is not in the patient's best interest. To something about these arms, so there's now essentially 4 arms that someone can be randomized to: the no corticosteroid arm, the fixed dose hydrocortisone, which is a 1-week course of IV hydrocortisone at 50 milligrams Q6. Also the shock dependent hydrocortisone, which is IV hydrocortisone, also at 50 milligrams Q6, but only while the patient is in shock. These doses, these arms all existed before, and now this new arm of fixed duration dexamethasone, which is IV or enteral dexamethasone at 6 milligrams daily for 10 days, but with dose adjustment for pregnancy, and also in children, it is weight-based dosing. As always, if you have any questions, you can reach us at www.remapcap.org. Thanks so much.
Okay. So, and just to emphasize, as I mentioned before, that for children, it's only the dexamethasone intervention that we have, not the hydrocortisone. That's adults only. So just to summarize, the eligibility for the individual domains varies between them. And remember, patients may be eligible for one or more domains. For the antiviral domain, it is only that they have to have confirmed influenza infection by any means, but microbiology proven influenza A or B infection. And then, as I said, specifically, then we want to treat people early in their illness. So within, in this case, 96 hours of hospital admission if they're on the ward. If they're critically ill, it's within 48 hours of ICU admission. We want to randomize patients before they've already been treated. So we're saying before they've received 2 doses of oseltamivir. And this is, I know, a challenge. Many people, clinicians, are used to giving Tamiflu for flu-positive patients in hospital. But as Chris Whitty sent round a letter last year reminding us, there is no RCT evidence of the benefit, and then maybe none, and there could always be harm. So if we can possibly randomize these patients before they've got their second dose of oseltamivir, but if they've already been treated, then it's too late to randomize them in this domain. Obviously, it would be 1 dose of baloxavir has a longer half-life, but I don't think many places are using baloxavir in normal clinical practice. Another exclusion is simply allergies, and as you heard, and hopefully not too big an issue in the pediatric population, but if you did have any pregnant patients, they can be randomized to the oseltamivir control, but not to baloxavir. And for the steroid domain to be eligible, we just, again, based on the evidence we saw with COVID, we feel that they need to have some evidence of pneumonitis. So any form of supplemental oxygen makes you eligible for the steroid domain. And again, exclusions treating patients early if they're critically ill. We want them in the first 24 hours of their ICU admission. And again, if they're being given steroids for another unrelated condition, obviously they can't be randomized. And hopefully there's no allergies to steroids, but that would be an exclusion should there be such one. And just for completeness, we don't have it open right now, but we will be opening it. And again, it may not be such an issue in children, but in adult patients. But it can include the sick patients on PICU. If they have confirmed influenza and are critically ill, i.e. receiving the organ support, they could be randomized within the immune modulation domain. And we would simply exclude those who are immunosuppressed, neutropenic, if they have active TB or invasive fungal disease, or if they're already being treated with the drugs, or if they again have an allergy.
All right, so I think we were just going to give a little bit of a reminder, an update about dosing. So these are the antiviral interventions that we mentioned. So it would be testing whether any treatment makes a benefit versus 5 or 10 days of oseltamivir, and the dosing. So basically, you could use your local hospital stock, and the dosing would be as per your local guidelines. However, if you would rather use the dosing that we're recommending, it would be 6 milligram per kilo per day divided into 2 doses for children up to 40 kilos. And the protocol has some information about dose adjusting for renal dysfunction. And it should be stopped either when they've completed the treatment course or when they go home, whichever occurs first. Oh, sorry, I'm trying to get rid of a message that popped up. I think not all sites might sign up for the 10 days of oseltamivir. So baloxavir is slightly complicated for pediatrics because of the preparations that are available. We were hoping to have a suitable oral preparation for all ages to take, but unfortunately it doesn't happen. So baloxavir is given on day 1 and 4 of admission, and can be given in combination, and would also be given in combination with oseltamivir for either 5 or 10 days. And the dosing is below. So if you're under 20 kilos, it's 2 per kilo, 20 to 40 kilos or 80 milligrams, and greater than 80 kilos is 80 milligrams. And it doesn't need to be adjusted for impairment. And the reason it's complex is that we have a preparation that we can give that's very unpalatable, and we think it's very unlikely, and it's a relatively large volume. We think it's quite unlikely that most children will take it. However, if a child had a PEG or an NG tube, then it could be suitable to be given through that. And so it may be that the children would only be eligible if they're able to tolerate it, or if we can give it through a tube, so those children who are intensive care or moderately unwell with an NG tube or PEG on the ward. And so it may not be suitable necessarily for all children with moderate disease for that reason. And then the corticosteroid domain is either the 10 days of dexamethasone or nothing, whether you're in the moderate or severe arm, and that's 10 days or until you're discharged, similarly to what we do for COVID. We anticipate most children hopefully won't need the full 10 days because they'll go home. And they shouldn't have any further steroids until after day 28. Unless they develop a new illness. So I guess if they had an organizing pneumonia would be the typical thing on the adult side, or perhaps if they had severe ARDS and we were considering using steroids for treating that further down the line. And it can be given either intravenously or enterally with the maximum of 6 milligrams daily. And that's a once daily dose. So what do you need to have as a site to take part? We need to have approval to go forward and to have access to the domain pages for both antiviral and the steroid domains. All of the training logs are available on the REMAP CAP website, which is remapcap.co.uk. And the oseltamivir and dexamethasone will be hospital stock. Once your site is ready to go, you'll be sent an order form, and then the drug will be delivered within a couple of days once you're activated at the site. But the REMAP CAP team who are online here with us are extremely responsive, and the email is just here. So if you have any queries or questions, they're very helpful and will be able to help you to get your site up and running.
Yep, so I'll just step in where Liz left. So yeah, we have our website address here. So our website includes separate pages for the ICU ward and paediatrics. We'll hope to have some training videos covering the SIV, so that's coming soon. Lots of training materials on the website available already. And then we'll include some REMAP CAP bites as we go through. We do have a consent animation video as well, and we'll update newsletters, and we've got document trackers on there as well. So hopefully it includes everything that you need. We will be having monthly Q&A sessions. So we've found that as sites are activating to the study, once you start actually running the study, various questions come up. So we found that monthly Q&A sessions really help in that sites can share experiences and techniques and what works well for them. So we'll start running those probably from next month. So we'll have the link for those on our website, and we'll also send it out by email as well. Just a bit about monitoring. So our study will incorporate all of central, remote and on-site monitoring. On-site visits will be arranged separately for ICU and ward and paediatric teams. So if your site covers all of these areas, we will arrange separate visits for each of the teams. We aim to arrange the first visit after the first 3 patients are recruited or within the first 6 months of randomization. And during these visits, we'll check the following things. So consent forms, processes, selected SDV, so patient check, ISF and pharmacy time. And this is a slide with our contact information. So hopefully you'll have this already. So our email address is here, ukremapcap@ignac.org. And then we have the EU website there, but we are your first point of call, and then our website below. So remapcap.co.uk.